Hi everyone, here is my presentation of methadone in pregnancy. What is methadone? Methadone can be described as an treatment that is administered daily by a registered opioid treatment program to pregnant women or as well as non-pregnant patients with opioid use disorders. It should be part of a comprehensive treatment plan that includes addiction, counseling, family therapy, nutritional education, and other medical and social services as needed. Some epidemiology factors. First, to start off with neonatal abstinence syndrome, also known as NAS or NOS. It affects 60 to 80% of neonates who are exposed to heroin or methadone while they were still in the room. To describe NAS, it could be described as low birth weight, respiratory discomfort, feeding difficulties, tremors, increased irritation, screaming, diarrhea, and in rare cases, convulsions, which are all considered as symptoms. Despite the fact that pharmacologic treatment for opioid use disorder, such as methadone, can cause NAS in pregnant women, ACOG advises against tapering pregnant women off of treatment because of the risk of addiction relapse, which could be far more harmful to fetal and early child development. Some factors, especially in Massachusetts, between 2012 and 2014, 17,568 adults in Massachusetts survived an opioid overdose. Methadone users had a 59% lower risk of dying from an opioid overdose than those who did not receive medication-assisted treatment. Patient presentation as well as differential diagnosis. On a patient who presents with altered mental status, initial lab work, a complete history, and a full exam should be undertaken. This workup should include a urine drug screen, ethanol level, fetal ultrasound, urinalysis, CMP, CBC, and vital signs. Monitoring for symptoms of withdrawal or substance abuse, are important as part of patient presentation such as monitoring behavior and actions, irritability, restlessness, anxiety, and night sweats. Risk factors of methadone include usage during pregnancy has been linked to increase of low birth weight and early delivery, also known as preterm. According to study, birth before 37 weeks of pregnancy. If a patient takes more methadone than their healthcare physician recommends, these results can be more than likely. Methadone is found in trace amounts of breast milk. However, the amount varies from person to person, as well as dose to dose for the patient. And as mentioned in my previous slides, NAS is a risk factor as well. Prenatal care for those on methadone. Laboratory tests such as urine toxicology testing is performed to determine whether someone is still misusing drugs. Toxicology testing is done as well, with the frequency of testing varying depending on the stage of treatment. Non-pregnant adults with a methadone level of 300 to 400 have an adequate total methadone dose and a lower risk of heroin addiction. This varies in pregnant results as there isn't a proper level of methadone that should be monitored. The most important piece of methadone treatment in prenatal care is coordination of care between OB and other doctors that are essential to the patient, such as addiction medicine, psychiatry, primary care, pediatrics, as well as social services. Extended antepartum fetal testing, such as non-stress tests, BPP, doesn't improve pregnancy outcomes in patients who consistently display high adherence, as seen by negative urine screens, or who have no normal grounds for fetal surveillance. Patients who do have evidence of ongoing substance use or who have other fetal surveillance, such as preeclampsia, fetal growth restrictions, should have fetal testing done weekly or twice weekly during the third trimester, as these pregnancies are more likely to have abnormal fetal testing that requires intervention. An important factor to minimize the chances of a non-reactive non-stress test or a low BPP score linked to opioids, the test should be should be performed at least 4 to 6 hours after the methadone therapy has been completed. The test should be done right before you take the drug if you're undergoing daily fetal monitoring. Overall, the goal is to provide proper care to our OB patients. So when combined with regional or local anesthetics, methadone has no side effects. The goal of pain therapy is to provide enough while avoiding over-medication and withdrawal. And that concludes my presentation.